Now let's talk about melanoma or malignant melanoma. This malignant melanoma or melanoma can be asked as a 4 marker, or sometimes, rarely, it can be asked as a essay also. So I'll just tell you the headings and what all things you have to write in those particular headings. I have taken my points from SRB surgery manual and Marrow edition 5 notes. So let's start. What is this malignant melanoma? It is a malignant tumor that is arising from epidermal melanocyte, which is one of the most aggressive cutaneous malignant tumor. Malignant melanoma, or malignant tumor, it is a malignant tumor that is arising from the epidermal melanocyte. Malignant tumor arising from epidermal melanocyte, which is one of the most aggressive cutaneous malignant tumor. First sentence. And it is of neural crest, that is ectodermal in origin. It is neural crest, that is ectodermal in origin, and it is 20 times more commonly seen in white individuals than blacks. So, once again, malignant melanoma, it is a malignant tumor that is arising from the epidermal melanocyte. Melanocytes in the epidermis, and which is one of the most aggressive cutaneous malignant tumor. It is a neural crest in origin and 20 times more commonly seen in whites. Now let's see what are the common sites where we are getting this malignant melanoma. Head and neck region 25%, lower limb, trunk. So there are 3 points that are having 25%. So remember those particularly head and neck, lower limb, trunk. In head and neck, lower limb and trunk. That is the most common sites where we are getting the malignant melanoma. Now let's see what are the risk factors for this condition. Exposure to sunlight. Most of the skin conditions we discussed, like squamous cell carcinoma, basal cell carcinoma, everything is having exposure to sunlight as a risk factor. So remember that in skin disorders, exposure to sunlight, and also ethnic factors, socio-economic status. Here the socio-economic status of high standards, lifestyle, climate, etc. Albinism, xeroderma pigmentosa, junctional nevus, familial dysplasia, nevus syndrome, etc. etc. There are so many risk factors. Don't forget sunlight. And albinism is also common in those conditions also. Xeroderma pigmentosa, it's also there in small cell and basal cell carcinoma, junctional nevus, familial dysplasia, nevus syndrome. Now let's see types. So first definition and some introductory points that you have to write. Then you have to write the risk factors, and then you have to mention different types of malignant melanoma. And these types you can remember with a mnemonic SLAND. I have mentioned in the left corner. SLAND, SLAND. S for superficial spreading type, L for lendigo maligna, A for acral melanoma, N for nodular melanoma, and D for desmoplastic melanoma. So once again I will repeat all these. SLAND. So it's a mnemonic to remember types. SLAND. Now let's start. What is superficial spreading type? It is having the prolonged horizontal phase, and it is most commonly seen in young individuals, and it is seen in the sun exposed areas, and it is the most common melanoma to develop in a pre-existing mole. Here I have shown a picture of the foot, like how it is appearing. Superficial spreading type. It is spreading type, and it is the most common melanoma that is to develop in a pre-existing mole. So these are the points that you have to write while mentioning superficial spreading type. So SLAND, superficial spreading type. Second one, L, lendigo maligna. It is an in situ condition, lendigo maligna, and it is seen in elderly, and it is having the best prognosis, and it is also known as Hutchinson's melanotic freckle. So 3 points. It is seen in elderly patients, it is having the very best prognosis, and it is also known as Hutchinson's melanotic freckle. Here you can see the picture. That is how the lendigo maligna appear. So superficial spreading type is over, lendigo maligna is over. The third one, A, acral melanoma. It is the most common melanoma that is occurring in the dark-skinned individuals. We know that malignant melanoma is occurring more commonly in white individuals. That is 20 times more common in white individuals. Acral melanoma is the melanoma that is most common melanoma that is occurring in the dark-skinned individuals, and where palms, soles, etc. And it is having the rapid vertical phase, and it is the most aggressive. Here you can see the picture, melanoma in the soul. Now let's see the fourth one, nodular melanoma, SLAN. N is for nodular melanoma. It present as a nodule. You can see in these 2 pictures, it is presenting as a nodule, and early and rapid vertical phase will be there, and it is having very worse prognosis. In the left side you can see the nodular malignant melanoma picture, And the right side you can see a variant of nodular melanoma that is known as a melanotic melanoma. From the name only you can understand a melanotic, so it is not having any pigment, so it is appearing as a soft tissue sarcoma and it is having very worse prognosis. So nodular melanoma you can write as it is appearing as a nodule, it is having very rapid vertical phase, early and rapid, and it is having very worse prognosis, and it is one of its variant is a melanotic melanoma without any pigment and all. So it will appear as a soft tissue sarcoma, but it is actually a melanoma and it is having very worse prognosis. So that is for nodular melanoma. The last one, desmoplastic melanoma. It is seen in the head and neck regions, axilla, etc. It is having perineural invasion. Perineural invasion. It is very painful and increased loco-regional recurrence. Here one picture I have mentioned, that is aggressive melanoma, desmoplastic type. It is in the axillary region. So these are the 5 different types that you have to remember. Slant is the mnemonic to remember. Superficial, spreading type. L for lentigo maligna, and A for acral variety, acral type, and then N for nodular and D for desmoplastic. I guess it's clear. Now let's move on to the clinical features. It can start in a pre-existing nevus or as a de novo in the normal skin also. Mostly it will be starting it as from the pre-existing nevus, but it can appear in the de novo skin also. Melanoma is unknown before puberty. Most commonly the melanoma is appearing after puberty only. Induration is not seen in melanoma, and pigmentation with irregular surface and margin with rapid growth. Ulceration, bleeding, itching and change in color will be present. So these are the clinical feature points that you have to mention. It can start in a pre-existing nevus or it can even start as a de novo in a normal skin. And melanoma is unknown before puberty. Induration is not seen in melanoma. Pigmentation with irregular surface and margin with rapid growth. Ulceration, bleeding, itching, change in color, etc. can be seen. Now here there are 4 different things that you have to notice from this picture. First one on the left side is Glasgow checklist point. Glasgow 7 checklist point. You know Glasgow coma staging and all. Here it is for malignant melanoma. It is having major criteria and minor criteria, and this each major criteria is having 2 points each, and each minor criteria is having 1 point each. Let's see what are the major criteria. Change in size, shape, color. Change in size, change in shape, or change in color. Size, shape, color. It is easy to remember. So anything is there, for each you have to give 2 points. And minor criteria, it is having only 1 point each. If the diameter is greater than 6 millimeter, inflammation is present, oozing is present, or change in sensation. And if the score is greater than 3, then it is very significant. So that is Glasgow 7 checklist point. Glasgow scoring point. Major criteria is having 2 points and minor criteria is having 1 point. Major criteria size, shape and color. Minor criteria diameter and inflammation, oozing, change in sensation. And one more thing is there, A, B, C, D, E of melanoma. These are all clinical along with diagnostic features. A, B, C, D, E of melanoma. It is also called ugly duckling sign. Ugly duckling sign. What is A? A for asymmetry. The lesion will be asymmetric and the border is irregular. So A, D. A for asymmetric, D for border irregularity, C for color variation, D for diameter greater than 6 cm, and E for evolving. So that is the A, B, C, D, E of melanoma. It is also known as ugly duckling sign. Coming to the right side, unlike to the squamous cell carcinoma and basal cell carcinoma, it will spread through lymphatics and it will spread through blood. Basal cell carcinoma we have already told, it will not spread through blood and all, but it is locally invasive. Here it is not the situation. It will spread through blood, lymphatics and all. So through lymphatics it can spread to the regional lymph nodes and other etc. And through blood the secondaries can be to the lungs, liver, brain, skin, bones, etc. That's it. Coming to the staging. While talking about the staging, you have to remember 2 classifications, Clark staging and Breslow staging. On the left side is given Clark staging and the right side I have given the Breslow staging. Clark staging is depending upon, there are 5 different stages. The one is intraepithelial, and if it is invading the papillary dermis, it is stage 2. If it is completely involved the papillary dermis, that is dermal papilla invasion, it is grade 3. And then stage 4 is reticular dermis and stage 5 is subcutaneous tissue. So staging 1, 2, 3, 4 and 5. Clark staging is also there. Breslow staging is also there. In one of the questions, they have asked Breslow staging as a 2-marker. So it can be asked separately also, so you have to keep in mind. What is Breslow? Breslow, it is in the right side. It is having 4 different stages. Stage 1, stage 2, stage 3 and stage 4. You have to remember about around 3 values like 0.75 mm, 1.5 mm, 4 mm. That's it. Only 3 values. 0.75. Stage 1 is less than 0.75 mm. Second is 0.76 to 1.5. Then 1.51 to 4 mm and more than 4 mm. So only 3 values: 0.75, 1.5 and 4. So all these values will come under in these 3. You can just put it off, and less than 7.5, 0.7, less than 0.75, 1, 2, 0.75 and 1.5, 3, 1.5 and 4, and 4 is more than 4. That is the Breslow staging for malignant melanoma. Clerks, you have to keep in mind, first is intraepithelial, second is papillary dermis, third is dermal papillae invasion, 4 is reticular dermis, and 5 is subcutaneous tissue. So this is the 2 staging that is available based on the depth of invasion in malignant melanoma. I think it's clear. Now let's see the differential diagnosis. You can write the differential diagnosis the other skin conditions: squamous cell carcinoma, basal cell carcinoma, seborrheic keratosis, Kaposi sarcoma, solar keratosis. You can write in like at least you can write SCC, BCC and malignant melanoma to each other. Like you can write it as is, at least 2 you will get. So that's it. Coming to the investigation part, we should not do any incision biopsy because it is a malignant metastatizing tumor. So you should not make any blood spread. So no incision biopsy is done, and excision biopsy is done of the primary tumor, and if punch biopsy is done if the tumor is large. So no incision biopsy is done. Excision biopsy is done if it is a primary tumor, and the punch biopsy is preferred if the tumor is so large. And FNAC of the lymph node is done because lymph node metastasis is there. So FNAC of the lymph nodes are done. US abdomen. Why US abdomen? To see the secondaries. Liver and all, I have told, blood spread will be there. So to see the secondaries, you can do US abdomen. Chest X-ray is also for the lung secondaries. CT, head, chest, abdomen, pelvis. These are all according to the places where we suspect the metastasis. And sentinel lymph node biopsy, MRI and PET scan to see. PET scan is again to see the metastasis. Dermoscopy. So these are the investigation things that you can do. I think it's clear. No incision biopsy should be done. Excision biopsy of the primary tumor, and punch biopsy is preferred if the tumor is large. FNAC of the lymph node, US abdomen, chest X-ray, CT head, chest, abdomen, pelvis, sentinel lymph node biopsy, MRI and PET scan, dermoscopy. Now let's see the management. There are so many types, like so many different managements. So I will just tell simply like what are the things you have to do. The main management of melanoma is surgery, and if it is a primary lesion, hand-lace wide local excision is preferred. So if it is a primary lesion, hand-lace wide local excision is preferred, and depending upon the depth of the lesion, we will choose the margin. If it is in situ lesion, margin should be 0.5 centimeter, and if the depth of the lesion is less than 1 mm, it should be 1 centimeter, 1 to 2 mm, 2 centimeter, greater than 2 mm, 2 centimeter. Like if it is the depth of lesion is mm, you have to write the margin in centimeter. That's it. Same. In situ it is 0.5. Everything else less than 1 mm, 1 centimeter, 1 to 2 mm, 1 to 2 centimeter, greater than 2 mm, 2 centimeter. That's it. So that's the thing. So surgery, primary lesion, hand-lace wide local excision. Coming to the lymph nodes, if the lymph nodes are involved or if lymph nodes are present, we should do the lymph node clearance surgery. That's it. And if the lymph node is absent, sentinel lymph node biopsy should be done to see whether the lymph node is involved or not. That's it. Then metastasis is very common. The most important prognostic factor in this condition is lymph node status, and the most important prognostic factor in melanomas not involving lymph node is depth of invasion. So with depth of invasion, we will be staging the cancer, and most important prognostic factor is lymph node status. And most common site for the distant metastasis is lungs. That's why we are seeing the CT and the chest X-ray of lungs. Like management of metastatic melanoma. So surgery is for non-metastatic. If it is already metastatized to the distant sites, what we have to do? We are having immunotherapy. And what are the drugs we can use? Dabrafenib. It is a BRAF inhibitor. Dabrafenib, trametinib, ipilimumab. That you have to you have to keep in mind these names. dabrafenib, trametinib, ipilimumab. Dabrafenib, trametinib, ipilimumab. And also, what are the markers? Immunohistochemistry markers: HMB45, S100, melan A. HMB45, S100, and melan A. These are the tumor markers that you will get. And the immunotherapy, if it is metastatic melanoma, you have to use DTI. DTI, dabrafenib, trametinib, ipilimumab. Dabrafenib, trametinib, ipilimumab. That's it. And I'll show some pictures. Here you can see malignant melanoma with lymph node secondaries, different individuals. Okay, and here you can see the lymph node involvement in the inguinal lymph nodal involvement. In the foot you can see, soles you can see, secondary tumors you can see. That's it. So that's it, guys. I guess you guys understood what are things to be written if the malignant melanoma or melanoma is asked as a question. So thank you all. Have a nice day. Thank you for your time.